Imagine for a moment that you're caught in the middle of a storm. Your home has been destroyed, and you're with the person you love the most. Maybe that's a child, or a parent, a sibling, or your spouse. It's dark and it's cold, and the hurricane-force winds and the torrential downpours threaten to pull you apart as you cling together. Those rains and winds accelerate, and you're being slowly but surely pulled apart. You reach out for each other time and time again, and your hands touch only briefly. You're sobbing uncontrollably, and before long, they're gone. There are thousands of Long Island families who are caught in a storm right now. There are 442 Long Islanders who lost their lives in that storm in the last year, and we're going to lose even more in 2017. You see, 442 Long Islanders and more than 52,000 other Americans last year lost their lives to drug overdoses. All of those drug overdoses were directly connected to prescription pills, painkillers, like OxyContin and Vicodin and Percocet and fentanyl and heroin, or some combination of those drugs. But more importantly, all of those fatalities were directly linked to a disease. It's a disease of addiction, a brain disease that's preventable, that's treatable, and for which death needn't be the outcome. Yet, when we think about the number 442, that's more than one per day. That means that by this time tomorrow morning, some Long Island family, probably within a few miles of here, will begin making funeral plans for a loved one before breakfast. Addiction has hit Long Island hard. Like any other natural disaster, it's destroyed homes, it's upended communities, it's claimed lives. Long Island wasn't ready for this. You know, we mourned when David Laffer burst into Haven Drugs in Medford on Father's Day in 2011 and mowed down 4 innocent people in his quest for prescription drugs. We cheered when we saw a dozen doctors and healthcare practitioners arrested locally for running pill mills and writing fake prescriptions. Then we bristled a little bit when the Long Island Expressway became known nationwide as the heroin highway. But we failed to connect the dots. We failed to sustain our attention. We ignored the warning signs and the dire forecasts about the storm. We ignored the dramatic increases in drug-related arrests, the treatment admissions, and the overdoses. You see, heroin doesn't happen here. It happens somewhere else to someone else. When we think about the average heroin user, it's the chronically homeless guy stumbling around the Lower East Side with a needle in his arm. It's not the perky cheerleader from Garden City. It's not the honor student from Smithtown. It's not the scholar athlete from East Hampton. It happens somewhere else to someone else. And when it happened to our kids, we chalked that up as lousy choices, or poor parenting, or lousy morals. In doing so, we gave heroin a 10-year running head start. And now we're trying to catch up. You know, this isn't the first natural disaster that Long Island has faced. In 2012, Hurricane Sandy swept in, did a lot of damage, and claimed 13 Long Island lives. And in the wake of that storm, we did a postmortem and said, what went wrong? How come we weren't better prepared? Probably individually, we all have a lot more flashlights and batteries in our houses now. Collectively, here on Long Island, we took steps to secure our shorelines, to amp up our power grids, to rebuild our infrastructure and make it stronger, to make sure that we were better prepared for the next 100-year storm. You know, we need to do the same thing when it comes to opioids and heroin and addiction. But here's the thing. Unless we take those steps, it's not going to stop. It's not like a tropical storm that'll just eventually blow out to sea. Unless we do something to stop it, it will worsen. It will continue. And here's the other thing. There's not just one big thing that we can do. There's no silver bullet that'll make it all go away and make it better. There are, however, a bunch of smaller things that we can do to begin to turn the tide. Let's talk about a few of them. We need to get serious about prevention. We need to get schools to understand that herding 500 kids into an auditorium for 45 minutes once a year in order to check a box isn't good prevention. Evidence-based, age-appropriate, individualized sessions that are integrated into 180 days of the school year from the very first day of kindergarten until the last day of 12th grade will absolutely make a difference. We've learned now that the DARE program didn't work, and scaring kids doesn't work. The potential consequences associated with drug and alcohol use are serious enough. We don't need to exaggerate them in order to get our kids' attention, and when we do, they tune us out. We've got to make sure that our messages are relevant. With some kids, we should be talking about how the use of alcohol and marijuana can be a gateway to other things. But for kids who are already experimenting and smoking pot, we're not necessarily talking about marijuana as a gateway drug. We should be talking about it as an exit drug. And as we give kids straight up information in a way that's honest and forthright, let's also understand that we've got to help them build some core competencies. If we can help kids learn good communication skills, good decision-making skills, good refusal strategies, those are competencies that protect them from a whole bunch of things, including drugs and alcohol, but from a whole bunch of things as well. Let's help kids talk about and manage the anxiety, depression, and stress that comes along with adolescence, that comes along with high-stakes testing, that comes along with overscheduled lives. Let's give the same factual, straight-up information to their parents. No judgments. Show them the science and the data, and then help them translate that information to their kids in a way that's sustained, that's loving, and that's designed to stick. Let's help those same parents come to terms with their own substance use, past or present. And let's help them to understand that the drugs of today and the potential consequences associated with their use are dramatically different than they were perhaps 30 years ago. Let's make sure that all kids and adults are screened for mental health disorders and substance use disorders as often as possible. Let's make sure that every healthcare practitioner is talking to every patient during every visit about their emotional well-being, about how much they're drinking, about their use of tobacco products, about their use of other drugs, and about their non-medical use of prescriptions. For those that need addiction treatment, let's make it available on demand. There shouldn't be waiting lists. I shouldn't have to show up at an emergency room at 4 a.m. to get first online in order to get a treatment bed. I shouldn't be sitting in my home frantically dialing substandard treatment facilities in Florida that advertise on late-night TV. Addiction treatment should be evidence-based. It should be culturally competent. It should be individualized to the person and their needs. And yeah, again, it ought to be available on demand. It shouldn't be difficult to find a treatment facility that specializes in co-occurring disorders, where a substance use problem runs concurrent with a mental health issue. Let's make it easy. Let's assume that everyone has a co-occurring disorder, because they probably do. Let's prevent insurance companies from requiring that folks fail first at outpatient treatment before they'll pay for inpatient treatment. When a line of healthcare professionals are telling that person, you need to go inpatient, you've been using 15 bags of heroin a day for 2 years, you're going to die if you don't go. Insurance companies shouldn't be allowed to say no. And when a healthcare professional recommends 30 days worth of treatment, they shouldn't stop coverage on day 5. It shouldn't be so hard to find treatment for parenting and pregnant moms. It shouldn't be so hard to find treatment for young women who are struggling with eating disorders and addiction. It shouldn't be so hard to find trauma-informed care, because here's a newsflash. Trauma is now the rule rather than the exception for a lot of the folks we're dealing with. The bottom line here is, until we make it easier to get treatment than it is to get heroin, we're not going to turn the tide. You know, there are multiple paths to recovery. For some people, it all starts in a church basement. For others, it starts in a wilderness program or a traditional treatment center. Some people use medication-assisted treatment. There are multiple paths, and that's a good thing. All of them should be laser-focused on addressing the biological, the psychological, and the spiritual components of addiction. But I've heard folks complain that some patients are on methadone for 20 years. So what? Well, the promise of a medication-free life is a gift. It's not reality for everyone. We don't tell diabetics, enough with the insulin, stop using it as a crutch. I've heard people suggest to me that if you use buprenorphine or Suboxone to curb the cravings associated with addiction, you're simply trading one drug for another. But if we truly in our hearts believe that addiction is a biologically based phenomenon, rather than a failure of willpower, then having a pharmaceutical intervention in our toolbox makes perfect sense. Here too, when doctors treat folks who are at elevated risk for heart disease, they don't tell them to suck it up and spend more time on the treadmill. They prescribe statins. They recommend a healthy diet. And they recommend a moderate exercise plan. They use every tool available in that toolbox to get that person well and to keep them safe. We ought to be doing the same here. The carnage on Long Island would be even worse if it weren't for a drug called naloxone, otherwise known as Narcan. It's an opioid reversal agent. And police officers and EMTs and even lay people are using that drug to bring people back from the brink of death. But as we resuscitate those folks, we got to make sure that we're linking them up to treatment. We got to make sure that we're helping and guiding the families who are affected by this. And we've got to make sure that giving somebody the ability to breathe again, it should be the least we can do, but it shouldn't be the best we could do. You know, creating a life is different than saving a life. And as we help folks remove drugs and alcohol from their daily routines, we have to help them add something back in. We've got to give them the skills and the knowledge and the attitudes necessary to be successful for the rest of their lives. Treatment only lasts for a short time. Recovery is a lifelong proposition. We've got to do more to support people in recovery, as well as their families. You know, here on Long Island, we recently opened a recovery center. That's great, but we need 12. We're having some really good and serious conversations about opening a recovery school on Long Island. But we need it today. I happen to believe that every school ought to be safe, sober, and conducive to a young person's recovery. They're not. And there's a growing group of young people who could benefit from a setting where your recovery comes first, social and emotional learning comes second, and academics comes third. That's how we save a generation. And while we're talking about saving generations, one of the greatest lessons we've learned out of this modern day crisis is that using a criminal justice response to a public health problem that's driven by a relentless brain disease is wasteful and counterproductive. Our jails and prisons are filled with folks who are struggling with untreated substance use disorders and mental health conditions. With 2.3 million Americans incarcerated, we no longer have room. Our facilities are full. It was okay, apparently, to lock up an entire generation of young black men for drug offenses. But Heroin 2.0 is white, middle class, and politically relevant. That's why we're suddenly talking about alternatives to incarceration and expanding drug courts and street-level diversion before people ever get into the system. That's why we're finally talking about some progressive solutions. But let's agree on this. Fairness dictates that everyone benefit equally from our newfound sanity. You know, when I started here this morning, I told you about those 442 Long Islanders. I wanted to get your attention. I hope I did. I didn't tell you about the thousands of Long Islanders who are recovering one day at a time. I didn't tell you about the lives reclaimed, the families reunited, the mom who got her son back this morning. The husband who got his wife back. I didn't tell you those stories, but those stories are what create hope in the midst of so much devastation. Those stories are going to power us through this crisis, and those stories help to eliminate the shame and stigma that not only surrounds addiction, but fuels the disease. It's really easy to say that the devastation we're experiencing today is unparalleled, but that's not true. How many American lives have been lost to chronic alcoholism, to impaired driving, to the heroin crisis of the 1980s and the resultant HIV/AIDS epidemic? How many futures have been lost to crack? Too many. This is our chance to make things right. This is our chance to become better prepared the next time around. Is the best time now? No. That was yesterday. That was 10 years ago. That was any time within the past century when we could have come up with a more creative, comprehensive, and compassionate approach to addiction. But the second best time is right now. It's right now. We need to help families who have lost a loved one rebuild their lives. We need to strengthen and fortify our schools and our communities. We need to shelter and support those who are struggling. And most importantly, We need to help those who have found a new way of living bask in the sunshine of their recovery. Thank you very much.